competition aimed at strengthening practical skills, clinical reasoning, and decision making in interventional cardiology. For this competition, we have received an overwhelming number of case submissions, and after a meticulous review process, our technical committee has selected the most challenging, insightful, and educational cases for today's presentation. So, a big congratulations to all our presenters. Your cases have been selected among the very best submissions across the country, and we look forward to learning from your clinical insights. So, let us now hear a message from Dr. Kamal Sharma, our course principal and scientific lead.
Hello and welcome to All India Complex PCI Case Study Competition, which is being virtually run and called the India Coronary Contest, which is supported by AstraZeneca. While leading operators from across the country in this program participate, which would benefit not only to as a learning, but as well as important take-home messages about how to manage complications when they arise. As a scientific lead and principal investigator for this study, I want to invite you all to attend, learn, and contribute to this science with eminent faculty across the country once in every week, as the timelines would be discussed with you, with 90 minutes of which would be looking at 5 fantastic cases across 10 episodes, and then to look at the finals where you would be judging the best case contributed into the platform. Looking forward to have you with the scientific learning across the board. Stay connected and watch out for the episodes across. Take care. Bye bye.
Thank you very much, Dr. Sharma. Going ahead with the presentation, please join me in welcoming our distinguished course principals for today's session. We're honored to have with us Dr. Dharmesh Solanki and Dr. R.K. Jain. I'll give a short introduction for both the speakers. It is my privilege to introduce Dr. Dharmesh Solanki, an interventional cardiologist and cardiac consultant at Wockhardt Hospital, Rajkot. With an experience of over 5,000 independent angioplasties, Dr. Solanki has been a pioneer in advancing cardiac interventions across the Saurashtra and Kutch regions of Gujarat. He is particularly known for his expertise in transradial coronary intervention and has a special clinical interest in left main and bifurcation stenting. He has previously served as a registrar at the LTMG Hospital, Mumbai, and a lecturer at UN Mehta Institute of Cardiology, Ahmedabad. We're delighted to have him with us today. A very warm welcome to you, Dr. Solanki.
Thank you.
Joining Dr. Solanki, we have our next distinguished principal for today, Dr. R.K. Jain, Director and Head of Department of Cardiology at Krishna Institute of Medical Sciences, Hyderabad. Dr. Jain is an accomplished cardiologist and researcher who has received several recognitions, including the CREATE Study Awards for Quality Data and Best Recruitment, the Best Reviewer and Reader's Choice Award from the Indian Heart Journal at CSI Chennai in 2016, and the Best Paper Presentation Award from the Association of Physicians of India, Andhra Pradesh chapter. He has also contributed significantly to cardiology literature through multiple book chapters and academic publications. A very warm welcome to you, Dr. Jain.
Thank you.
So before we begin with our expert talks, I'll quickly run through the agenda for today. First, we will have expert talks delivered by our course principals for today's session. After that, we will move to the 5 complex PCI case presentations that are scheduled for today. Each presenter will have 10 minutes to present their case, followed by a 3-minute Q&A session. So with that, let us begin with today's first expert talk. I would like to invite Dr. Dharmesh Solanki to deliver his talk on the topic, timing of dapagliflozin initiation post T2D PCI at discharge. Over to you, doctor.
Hello. Hello. Hello.
Yes, sir. So you are audible, sir.
Yeah, I'm audible and visible. So good
Yes.
evening, everyone, and I welcome you all for this particular unique session where there is a clinical as well as there is an interventional feast. So what I'm going to discuss in next 10 to 12 minutes is when diabetic ACS patients undergoing PCI, what is the role particularly of dapagliflozin or SGLT2 and when one should start. The initial part of the data of positive data of dapagliflozin or SGLT2 has come from very early study in a diabetic ACS patient undergoing PCI, and they found that the patients are showing reduction in NT-proBNP. There is a good remodeling process, and at the same time, subsequent study has been found to reduces the cardiovascular mortality, hospitalization of the heart failure, as well as there is a benefit in event rates of myocardial infarction and stroke. So, if we go to the first initial couple of slides for the data, how the diabetic ACS is differ and what one should do. If you look at the data, the ACS patient, almost nearly 45% of the patient has an associated comorbidity in the form of diabetes or they are pre-diabetic. Though diabetes is a macrovascular, cardiovascular disease in a diabetes is a macrovascular complication, but there are some data suggests that there is an increase in 1% elevation in HbA1c increases the cardiovascular rate, event rate by nearly 13%. And this is another interesting data which says that the patient, those who are pre-diabetic or non-diabetic, at the end of 12 months, after the ACS PCI, they either become diabetic or they become pre-diabetic. So this is again a very big sentence that pre-diabetic patients has transitioned to diabetic within 1 year. And this particular subset of the patient, if we start SGLT2 early, they are being prevented to become a diabetic and they are getting a benefit. And this is another interesting data where ACS diabetic was compared with the ACS non-diabetic, and ACS diabetic has a higher MACE rate, higher all-cause death, and they have a higher heart failure incidence. So clearly, the diabetic with the ACS is the worst combination to have as compared to the diabetic with non-ACS. It is not in-hospital mortality, but 12 months mortality is also higher with the diabetic ACS patient. Mortality also depends on duration of the diabetes. If diabetes is more than 10 years of duration, they have a higher mortality as compared to the diabetic duration of less than 5 years. So clearly, diabetic is a problem, duration of the diabetes is a problem, increase in HbA1c is a problem, and these all ultimately result in either a MACE, that is a 3-point MACE of CV stroke, non-fatal MI, and cardiovascular death, as well as hospitalization of the heart failure. Now, do we have the data which suggests that SGLT2 group of the drugs, particularly I am talking of the diabetic ACS undergoing PCI, has a benefit? So let us understand this meta-analysis which shows that diabetic ACS patients, if we start dapagliflozin early during the hospitalization or immediately post-hospitalization, reduces the myocardial infarction rate, relative risk reduction by 21%, MACE by 16%, and if it was started within first year of the ACS, then it further reduces MACE by relative risk reduction by 58%. Now, what is the ideal time to start the dapagliflozin or empagliflozin or any SGLT2 in a ACS patient? So this is a hypothetical slide that patients with the diabetic who more majority of the time may have a multivessel disease has come with the ACS. Let's say in January 2023, he has underwent LAD plasty. Again, after 1.5 years, he has again episode of ACS. Another plasty was performed to the right coronary artery, and a couple of months later, the stage angioplasty to the third circumflex was performed. And after another couple of months, patient has developed the hospitalization for the heart failure. Now, during this particular part where patient has only ischemia, if you add the dapagliflozin or empagliflozin, it prevents the MACE, which I had shown you. It prevents the re-MI and first hospitalization of the heart failure. And we all know that once the patient is being hospitalized for reduced ejection fraction heart failure, dapagliflozin or empagliflozin is the one of the fourth pillar for the heart failure treatment. Now, how early? Is it a 1 year? Is it in hospital? Is it 1 month? So this is another meta-analysis where 26,000 patients has been studied, where they've shown that dapagliflozin started less than 8 weeks after the myocardial infarction versus more than 8 weeks. And if you look at the mortality reduction, it reduces more better mortality outcome of 24% versus 19% those who are being started after 8 weeks. So dapagliflozin should be started ideally within first few weeks of following ACS angioplasty in a patients with the diabetes. So this is again shows that those who are being started early has been showing a benefit, either it is in the first or in the second year, but still the current data says one need to start at the time of the discharge. So do we anticipate any side effect, particularly when we are talking of in hospital or immediately following acute myocardial infarction? Many a times we are concerned with the ketoacidosis. We all know that hypoglycemia is the most deadly combinations with the acute coronary syndrome, which increases the cardiovascular mortality. We are worried about the worsening of the renal function many a times with the borderline blood pressure. But if you look at the dapagliflozin with the placebo, these side effects are statistically insignificant. Any serious adverse effect leads to probably discontinuation of the study drugs is also statistically insignificant. So in nutcrux, it is a very well tolerated, and one can start once the patient is off inotropic support, off IV diuretics, and it is to be started immediately to get the further benefit. With that data, American Diabetic Association has also said that patients with the atherosclerotic coronary artery vascular disease or those who are having a high risk in a type 2 diabetes, the drugs which is shows the benefit, either GLP-1 or SGLT2 should be started as a first line of therapy. And with that also, ACS Guidelines 2025, American Heart Association has also given a statement that one does not need to defer the ACS patients with the dapagliflozin or empagliflozin, particularly during the hospital discharge. So in nutcrux, what I wanted to convey is that ACS patient has a high comorbidity. Many of them are diabetic almost. Transition from pre-diabetic to diabetic over a period of 1 year is very high. Dapagliflozin and empagliflozin found to reduces the 3-point MACE, re-MI, hospitalization of the heart failure in a type 2 diabetes with the ACS. And maximum benefit has been observed when one should start, once the patient receives the treatment as early as possible. So thank you for your patience listening, and I will stop my sharing here.
Thank you, Dr. Solanki, for that informative start and also for setting the tone for today's discussion. I would now like to invite Dr. R.K. Jain to deliver his expert talk. His topic for today is optimization of MRAs in a hyperkalemic heart failure patient. Over to you, sir.
It was in the end, no? It's changed, huh?
Yeah, we have the expert talks in the beginning now.
Okay. You're able to see my slides?
Yes, sir.
Okay, thank you, AstraZeneca. And today's topic, I'm just waiting to see the fantastic cases done by the young cardiologist. Some of them looks interesting, the title at least. So my talk is optimization of MRAs in hyperkalemic heart failure patients. So we all know heart failure is a big problem, as Dharmesh Solanki has told just now, that the huge number of people, the burden is very, very huge. And the burden is not decreasing, it is increasing, not only in India, all over the world, because longevity is increasing, the heart failure is increasing also. And if you see the mortality, the 5-year mortality is as high as 50%. And you'll be surprised to know the heart failure mortality is worse than breast malignancy and prostate malignancy. We're all scared of malignancy, but heart failure is scarier than malignancy. But if you treated it well, it's going to be taken care of. Not only it causes mortality, it causes economic burden both to the family and to the nation. And even patients who have HepF also, 50% of the heart failure have HepF, unlike commonly everybody knows about HepF with reduced ejection fraction. And you know that if you start on GDMT, the 4 pillars, that is ACE inhibitors, ARB or ARNI, beta blockers, MRAs and SGLT, the mortality, the prolonged survival is by almost 6 years. So difference of 6.3 years can be made by using these 4 drugs in a patient with heart failure. But the problem is, it is possible to achieve GDMT, that is optimization of both RASI and MRA in real world clinical practice. So in real world clinical practice, only 33 patients of the eligible patients were prescribed for MRA. So this is from the real world practice. That is 67% of the patient didn't receive an MRA, and that is very, very unfortunate. And the biggest derailer of GDMT is a scare of a hyperkalemia. When I say hyperkalemia, I'll take it as 3.5 to 5 as a normal. Hypokalemia is less than 3.5 and hyperkalemia is more than 5. And this is the basic of hyperkalemia. And most of the physicians, some of the cardiologists and some of the nephrologists and diabetologists, whenever you give a combination of MRA and renin-angiotensin inhibitor, they're scared of hyperkalemia. So if you see what happens if somebody is on ACE, ARB and MRA, what are the hyperkalemia source? That is needing discontinuation of this medication, that is in patients with a CKD and or heart failure. So in ACE inhibitors, is 26% of the patients can have hyperkalemia, and ARB 25% get hyperkalemia, MRA 33% get hyperkalemia. But if we see the sad part, only 12% of the patient are reinitiated on ACE inhibitors, or 15% are reinitiated on ARB, and only 10% are initiated on MRA because of one episode of hyperkalemia. So these patients, that is 211 patients out of 6,000 patients, 143 patients out of 3,800 patients, and out of 3,000 patients, 78 patients, they are doomed to go for further episodes of heart failure, recurrent hospital admission, or sudden cardiac death. So second thing is, if you reduce the dose to prevent a hyperkalemia, also is as harmful as discontinuing these ACE, ARBs or MRA. So if there is a 55% increased risk with RAS inhibitors discontinuation, and 50% increased risk with RASI down titration. So similar is not same. If it's not same, it's almost similar. So even if you discontinue the drug or you down titrate the drug, the risk is almost half when compared to patients who continue this drug on maintenance therapy. So we have a new potassium binder, which is called as SZC, and this binder helps us to optimize these RAS and MRA induced hyperkalemia. If you see the p-value is 0.001, the occurrence of non-occurrence of, that means the treatment response can be done without hyperkalemia, is 71 versus 36. So that's an advantage of this. This is Reliance case study design. Most of the data is from this. This is a phase 4 randomized double-blind placebo-controlled international trial, and evaluated in SZC therapy for hyperkalemia can optimize and maintain MRA therapy for 6 months in adult patient who having heart failure with reduced ejection fraction, not on dialysis. And this is a trial design. And what it showed is a Lokelma, that is a SZC, delayed time to hyperkalemia event by 49% relative risk reduction. That's the first episode of hyperkalemia when compared to placebo, and the p-value is very, very significant. So even Lokelma helped to delay time to MRA reduction, that is 63% relative risk reduction, delay in stopping or decrease or discontinuation of MRA when compared to a placebo. So ESC guidelines support use of potassium binders. So ESC guidelines support, they say when the patient with a chronic or recurrent hyperkalemia on RASI therapy, an approved potassium lowering agent may be initiated as soon as the potassium level is confirmed as above 5. Why? administration of potassium lowering agents, that is sodium zirconium cyclosilicate or patrimar, may allow RASI initiation or uptitration in large proportion of patients. So how do you ensure that your patients maintain guideline recommend RASI and MRA therapy? So I just will go through a small case which we had recently. A 65-year-old male, CKD stage 3, is a de novo diabetic 7.5%. He was diagnosed as acute coronary syndrome, QRBB, anterior MI, and he didn't take any treatment. He is from Khajuraho. I am from Hyderabad. He traveled all the way from Khajuraho, and he had echocardiogram showed severe dysfunction, and angiogram showed recently, we just did a couple of days back, triple vessel disease, and we decided to get a PET CT to assess myocardial viability because it is less than 1 week. A cardiac MRI can't be used. And if you see, this is a GLS which is corresponding that the LED trajectory is not visible, and this is ECG showing anterior QRBB, and this is a PET CT shows there is a match between the perfusion and the metabolism. That means there is no metabolism, no perfusion in LED territory, and there's a mismatch in other areas. The other areas are viable. So we made a decision that LED is not viable, LED is infarcted, and we left the LED alone. So the patient had a creatinine of 1.7 at the time of angiogram, and the potassium shot up to 5.4. So my DNB resident asked to stop me MRA and ARNI. So, but there is a reduction. There's a great mortality benefit if you stop, if you don't start these drugs, and the patient is having heart failure. So what happened? We started this patient on Localma 5 milligram sodium because the potassium was 5.4 only, and the potassium dropped to 4.2. And then this already I told that there is a patient had a PET scan which showed non-viable myocardial hereditary, and while waiting for this, he again presented acute heart failure, and MRA and ARNI were added. And then the patient underwent a PTCA stent to mid RCA, and with a 4 into 34 millimeter stent. The RPDA was diffusely diseased, so we did a drug-eluting balloon 2.5 to 38. So, and this is the rails and EFISA study where all of us know 30% reduction in mortality and 15% reduction in all-cause mortality. So my message is here. This patient goes back to Khajuraho, and we are 2,000 kilometers away from it. So if I don't start an ARNI and MRA at this point of time, he's going to come back after 1 month. So whatever the mortality benefit, reduced risk of rehospitalization for heart failure, I'll be losing that. My resident said, sir, the patient is already 1 episode of hyperkalemia. If you start ARNI. So I stopped, and patient went to LVF, but somehow I managed with the diuretic, ARNI and MRA. The potassium was started shooting up again. And this patient I started on SZC 5 milligrams once daily only, because it's not gone beyond 5.5. But I thought whatever hyperkalemia he will not have, he'll do benefit. And he's gone back to Khajuraho, and he's doing extremely well. So this is how you have to use this drug in a current day practice. And thank you very much.
Thank you, sir. That was a very interesting perspective on guideline recommendations and the challenges to apply them. So after these enriching talks from our expert faculty, we will now move on to the presentations. So before we begin the presentations, a quick reminder for all our participants. Each presenter will have 10 minutes to present their case, followed by a 3-minute Q&A session. As this is a time-regulated session, I request all the speakers to adhere to their allotted time. I will also provide a reminder to you when you have 1 minute remaining. So without further ado, let us begin the first presentation. So our first presenter for today is Dr. Gaurav Khandelwal, and he'll be presenting his case on extensive coronary dissection. Dr. Khandelwal, over to you.
Yeah, thank you. So I'm just sharing my slides. So are they visible? Are my slides visible?
Not yet. Yeah, now.
So I'll be presenting a case of extensive coronary artery dissection. So this is a 47-year-old male who presented with recent onset, recent anteroseptal MI and he continued to have post-MI angina. He was a hypertensive. So his, I'll be sharing the ECG as well. His echo showed hypokinetic anterior territory, EF 35%, and CAG was already done outside, which showed proximal osteoproximal 100% occlusion. So this was the ECG. It shows like preserved R wave and inverted T waves. And so we started with the guiding, and we took EBU, and you can see there is this circumflex which is feeding faintly the LED. So, so we had no doubts about the viability looking at the ECG as well as angio and the echo. So the territory was preserved, viability was preserved. So, but if we have a look, we realized after taking the shoot that the EBU engagement was not coaxial, and before we could even change it, we realized that there is dye staining. So at this point, patient had chest pain, his BP started dropping, and we had to act fast. So we were lucky that our guide wire cougar went into the circumflex artery, and we can see the dissection right from the left main coronary artery extending into the left circumflex. And this was probably the reason, because the circumflex was feeding the LED. So that's what the patient was having hypertension. So the next step was stent jailing the dissected segment. And we first took 3.5 into 37 millimeter DES and deployed it in the circumflex from the osteoproximal circumflex to where we could see the dissection. So this was the result. And post-stenting, there was milking of the hematoma, and even the portion distal to the stent seemed to be affected. So our priority was now sealing the left main coronary artery. So in the cranial shoot, we deployed 4 into 13 millimeter DES from left main ostium to the proximal circumflex. And after that, the patient's condition stabilized a bit. And then we post-dilated it with a 4 millimeter NC balloon. Now, at this point, patient condition was stable. Because the LED was still not looking good, we thought that let us give an attempt if we could cross the LED. And before that, we sealed the distal circumflex with another stent, 3.5 millimeter DES deployed into the distal circumflex. And then we attempted the LED wiring with the pilot, and with a balloon support, we were lucky to get our wire past till distal LED. The video is not running here. Yeah, so we opened the osteoproximal LED and the struts with the balloon, graded balloon, first 1.5, then 3 millimeter balloon. And videos are not running. Yeah, then we deployed a 3.5 into 33 millimeter stent into the LED. And the kissing balloon dilatation was done from left main to LED and left main to circumflex, both about 3.5 millimeter kissing balloons. I'm sorry for the videos. Intermittently, they are not running. So a good result was obtained. This was the carina we achieved after the kissing. Sorry for the videos. So we even got the chance to do follow-up coronary angiography after 1 year, and the left main, the LED, circumflex, everything was patent. So non-coaxial EBU hooking caused this extensive dissection. Patient became hemodynamically unstable. LED was subacutely occluded and could have taken time. So fortunately, our wire went to the circumflex, and LCX was stented prior to LM stenting, as stenting through struts, if needed, could have been messy. And left main to ostium to circumflex stenting was quickly performed. And then T stenting was done into the LED, and kissing balloon inflation was done. So patient was stabilized as soon as the dissection got stented completely, and good immediate and follow-up results were achieved. And this patient followed up even 2.5 years later after the procedure, and he was asymptomatic. His EF improved to 45%. So learning points is the hooking, especially with some aggressive catheters like EPU, should be careful, and LM dissection can make patient unstable. And our priority should be to seal the entry point left main dissection and uh, adequate like final kissing inflations and all give good post-procedural long-term outcomes. Thank you.
So, Dr. Khandelwal, can you show the first NGO? Your guiding is deep inside. It is a coaxial, because if guiding is not deep inside,
Sure,
coaxial
sir.
nahi hota hai, so that cannot be possible, number one.
Yes,
Number
sir.
two is that there is a intramural hematoma which should not be stented, because as long as you keep on stenting intramural hematoma, the last
Yes, sir.
stent which you put was intramural
Yes, sir.
hematoma. So the treatment is the cutting balloon of appropriate size. And
Yes, sir.
lastly, while you are performing the LED angioplasty, you must have done the pot, because otherwise you may go subintimal into the between the stents and the
Yes,
left
sir.
main. So pot has to be done before going to the LED stent.
Sir, 4
Dr. Jain
millimeter.
can
Yeah,
no,
sir.
no,
4
you have not
yeah.
done the pot while going
After.
for the LED.
Yes, sir. Yes, sir.
Yeah,
But
so pot has to be done before, and this guiding is very deeply seated, and
yes,
because
sir.
of there is a forceful injection which has resulted in dissection. At least if you can freeze some frame, I could see
Yes,
some
sir.
flap which is started at the last two frame. The flap has started from the left main. Now go forward little bit. Go back. Go back. Go back. 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 No. 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 Not to go little. No. Back. Back. Die. थोड़ा bit. नहीं in between. Anyhow, but then there was
Yes,
a
sir.
yes. This was sitting deep inside. It was a
Yes, sir.
coaxial, but it was sitting
Yes,
deep
sir.
inside.
Yes, sir.
Yeah, now there is a flap which has started there, and
Yes, sir.
the you are lucky enough in getting into the true lumen, because
Yes,
if
sir.
two arteries are gone, he might have crashed on table.
Yes, sir.
Is the patient has any hemodynamic instability during the
Yes, sir.
procedure?
Yes, sir. So soon after we recognized dissection, the patient was having chest pain and hypotension.
Okay.
Yeah.
Okay, all end goods at the end of the day.
Khandelwal, I have one question. Why did you use a 7 French EVU? There was no indication to use 7 French. You are not going for upfront 2 stent strategy simultaneously. Okay.
Yes, sir.
So you should not have used 7 French at all. If you had
Yes,
used
sir.
6 French, this shouldn't have happened. Because the bigger the French, you inject a
Yes, sir.
contrast, chance of dissection. Second,
Yes, sir.
today you are participating in a contest, and if you say my videos are not running well, that is not a good excuse. Third, you have not shown the follow-up angiogram. You just told angiogram was done. So
Sir,
if you
I
want to
show,
really
yeah.
impress, so then that angiogram has to be shown.
Sir, this was the follow-up angiogram. Yeah,
Okay.
1 year later. Yeah.
Yeah, but then these 3 things, the videos should play. If they don't play the video, whatever
Yes,
great
sir.
case you have, it doesn't carry any meaning.
I agree, sir.
Okay, good luck.
Yeah.
Nice save. Okay,
Thank you, sir.
thank you.
Yep. Thank you, doctors. Our next presenter for today is Dr. Aditya Upadhyay. His topic is ostial left main CTO PCI. Dr. Upadhyay, over to you.
So, are my slides visible?
Yes,
Yes.
Yes.
Okay, just a second. So, I'm presenting a case of ostial left main CTO-PCI. So mine is a 58-year-old male who had no conventional cardiovascular risk factors with an history of ACS 2 years ago and was managed medically. But since last 4 months, he has an angina, which has come up to class 3. So the patient was wanted to get investigated. He had an ejection fraction of 25%, that is a severe systolic dysfunction. He got an angiogram done outside, which showed left main CTO. With a retrograde filling of the LED, I'll show the angiogram and subsequently. And from that center, he was referred for a CABG. but the patient was reluctant into getting one, and he came to us. So when we looked at the coronaries, we could see that it was filling. There was a CTO from the left main. We can see it in both the views, and it was filling retrogradely from the right injection up to the bifurcation, that is up to the LAD L6 bifurcation, and we can see that the right coronary is more or less good in condition. So now this was a very critical angiogram that we had, because here we had a retrograde filling which showed that it was a chronic disease. The patient has a CTO, and this showed that it was clinically a very complex case because it was a CTO first of all. Secondly, if we tried to go antegrade, we had risk of jeopardizing either of the LED or L6 if we are wiring the first one, because we may enter subintimally and we may cut off the other vessel. So that was a risk when we were choosing antegrade. But if we had to choose retrograde, we were like going through the only vessel that was remaining with the patient. So uh, so that was an issue. And also the major issue was that we could not go with an ADR or an RDR technique because we were at the aorta. And also the patient has a very lower ejection fraction that is up to 25%. So that was again a challenge in this case. But there was few things in our favor. If we evaluated it again, and we could see that there was a tapering, small tapering part from the left main, and the CTO segment was nearly less than 20 mm. So that was in favor of going ahead with an antegrade technique. But again, we had this problem that we would be landing up to a bifurcation. So we had in our mind that we might end up with a retrograde. But again, that was a very difficult possibility. We were going to chase retrogradely. And then we also had if we could go with a hybrid technique, or again convince the patient that we'll not go ahead with this if we are unable to cross it in the first scope. So with this thing, we moved ahead with an antegrade wire escalation strategy. We chose Fielder XT wire. We thought that it is a tapering end, so we could try with it, but we were unsuccessful. Then we went ahead with the Gaia first. We were still able to not cross. We took a Gaia second, and then we were able to cross ahead. But then our strategy was, since LED is the major vessel, so we thought that we'll enter into the LED. But then we realized that every time we were trying to get into the LED, we were going subintermally. So we thought, okay, wait, let's move to the vessel wherever the wire goes. So instead of chasing for a high myocardial value vessel, we let the wire move into the vessel that it was choosing. So it went through the low resistance path and entered the LCX. So we wired the LCX. We rechecked it with a retrograde shot, and we confirmed the position if it is in true lumen. But we wanted to be doubly sure. So within the second angiogram, we can see that we had again through the microcatheter that we were having, we took a dye shot with that, and we were confirming that it was in the true lumen. After this, we again went ahead with wiring with the towards the LED, and this time we were successful, and we wired the LED, and again we took a check shot, retrograde, as well as with the microcatheter. Now, the thing was, we did not balloon before wiring the LED, because we had if we ballooned and we were subintimally, we would have gone, we would have compromised the LED. So we avoided that. And once we had wired both the vessels, we pre-dilated the lesions and proceeded with left main bifurcation with the mini crush technique. So here we can see, after fixing in the first angiogram, we fixed with the distal vessels, and then we took the proximal LCX stent, we crushed it, and then we took another DS of 3.02 into 15 in the LMCA, LAD to LMCA, and then we were deployed it, and then we did a pot and rewired the L6, and then we did the casing, and we did the final pot with a 4.5 into 8 NC. So this was our final angiogram. We saw that it was a tapering. This was the first angiogram. We could see that there was a tapering tip and a significant CTO, and this was our final angiogram. We also have this patient at a 3 months follow-up, and patient is doing completely fine. He is on 75 milligram aspirin, ticagrelor 90 mg BD, rosuvastatin, ezetimibe, and sacubitril valsartan 100 mg BD, and metoprolol succinate of 50 mg. So what was the learning from my case was that LMCA CTO is very rare. We have acute occlusions, but getting a CTO is very rare, about 0.04 to 0.4%. The standard of care is always CABG. But with PCI, we want to do, there are two major challenges. That is, firstly, it is technically difficult across various studies. We have seen that success rate was around 40 to 81%. And it has a higher risk of occlusion of other vessel if we do ballooning after wiring the first vessel. So that was one important aspect, technical aspect. And LMCS CTOs with the we have performed, so we wanted to show that can be done successfully percutaneously if we have meticulous planning and the operator is sure about what he's going ahead with, and he has a multidisciplinary hard team approach that we have a backup of CVTs as well if there is a problem. So in that scenario, we can do LMCS CTO. Thank you.
Excellent case, Aditya. One comment and one question. Only single surviving vessel should not be attempted retrogradely. So your plan of retrograde is not exist for this particular cases, because otherwise he will crash on table if you are going through the RCA and your guiding is inside, your perfusion is almost practically zero. Second
Yes, sir.
is question is have you put the intra-aortic balloon pump, because the ejection fraction is very low, and to perform a complex angioplasty, have you put the IABP or have you considered IABP on board?
We did have IABP in backup, but since the patient had a good blood pressure of 100 by 70, and we knew that it is a CTO, so the vessels were not feeded from the left LMCA. So we thought like, okay, going ahead with it won't compromise because the circulation had already been established from the RCA. So we were not going to jeopardize any circulation. So we did have IABP in backup.
Okay.
Did you have an access at least? Did you keep an access ready or not? You didn't tell
Yes, we had an access. We had an access.
Punctured both the groins?
Both the groins. Yes, sir.
Okay. Good case.
Thank you, sir.
Thank you.
Yeah, we move forward.
Thank you, sir.
Yes, thank you, doctors. Next up, we have Dr. Anthony Wilson. His case is titled Synergistic Approach in Managing Balloon Non-Negotiable Critical ISR Lesion. Over to you, Dr. Wilson.
Good afternoon, good evening to everyone. So my slides are visible?
Yes.
Yeah. So I am Dr. Anthony Wilson from Apollo Main Hospital, Chennai. So here I am going to present. She's a 60 years old female, dyslipidemic, and she had anti-Olama in 2010, and she had undergone PCA to LAD and RC in 2010, and now she presented to us with complaints of retro chest pain. And ECG was showing on a poor RV progression and T inversion in the precordial leads. And echo was showing mid entry wall and apical septum, LV apex, hypokinetic, adequate LV function. So here the angiogram you can see there was a tight lesion in the LCX. In the apical view, you can see a critical ISR lesion in the LAD stent. So as a so we put one support wire in the LCX and run through wire in the LAD ISR lesion. So our initial plan was like we will do simply, it's look like simple lesion we thought, and we plan to go ahead with 2 mm or 2.5 mm NC balloon and open the lesion, then prepare the lesion with 2.5 or 2.75 mm cutting balloon according to the after the pre-dilatation. And we will put a stent of 2.75 or 3 mm regulating stent. Then we will plan to do 3 mm NC balloon. This was our simple plan when we saw the angiogram. So when we are trying to negotiate with the 2.5 mm balloon, 2 balloon, it was non-negotiable. Then we thought maybe there may be some wire bias, so we thought we will take one more body wire and we will try to do it. That also failed. Then we plan to go with the smallest balloon from 0.75 mm to then 1.5 mm Rayuri balloon, then 1.2, then 1.5 pre-dilatation when we prepared very well. And then they thought we will go as an initial plan 2 mm balloon. Then again, that 2 mm was not able to cross the even with the help of guide plus 2 ST guide extension catheter also. Then we kept as a plan B and we used 0.9 mm ELCA with the fluence from the 45 to 80 and repetition from 25 to 80 hertz. Used multiple runs. Then the lesion giveaway. Then we used again our original plan as a 2 into 8 mm NC track balloon initially, then 2.5 mm balloon. Then we prepared with an 2.5 mm, 10 mm Wolverine cutting balloon also. After well preparation, then we put a stent of 2.75 into 38 mm Onyx Frontier Medtronic stent. Then we post-dilated with a 3 mm balloon. And as you can see that the final result, it was well expanded, well post stent. So what is my take home message is like always keep a plan B always. Even a simple lesion may be complicated in the process, and patients while doing procedure should not be hurried while doing these type of cases. And ELCA is a good option for balloon non-crossable ISR lesions. Thank you.
So what is the first option for balloon non-crossable lesion? Because you have the facility of Alka because you are in a main Chennai Apollo, but then rest of the people, almost I would say 99.5% of the cardiologists do not have that facility. So what is the other option you would have thought of?
So I would thought of like starting from the after pre-dilatation from the smallest balloon to we upgrade.
Any other
And
things you can
It didn't
do?
work. No, it didn't work for you. So what would have
No,
done?
from the smallest balloon 1.5 to 2 mm used.
That's what you
The
did.
2
No,
mm was not going.
1.25 to
Yeah.
2.5. You did. Then you went for Elka, correct?
Yeah.
So
So
what
have
if
you
Elka
considered
was not
Maybe
rota?
there?
angioscalp balloon maybe help.
No, balloon won't go.
Don't
Angioscalp
go.
won't go. So first and foremost is
Correct.
rotablator because
Rota,
primarily
rota.
non-crossable lesions is the first and foremost is rota.
Yeah, but
Number
it's
two, have you
not
done
that.
IVUS because such a tough lesion, was it a fibrotic or fibrocalcified? Have you done IVUS on that?
No, not in this lesion. We didn't do the imaging.
Because ALCA is been done, then IVUS would have been probably help you in understanding what morphology of restenosis and how one could have been approached by saving some money because we all are India is a price conscious market. Anyhow, it's a nice case,
pricing was
but
not an issue. Yeah.
It's a nice case, but then I was rota. The basic things are probably not in that particular case.
Yeah.
Because this is educational forum, so that should be there as a first attempt.
Yeah.
Yeah, Dr. Jain, anything you want to add?
Thank you, Anthony.
Thank you, sir.
Thank you, doctors. Our next presenter is Dr. Krish Jivani. His case is titled Tortoise RCA Primary PCI, complicated with detached intracoronary guide extension. Over to you, doctor.
Yes, go ahead, Krish.
Yes. Yes. Is my slides are visible, sir?
Not yet.
Just I'm doing.
You are
Is my
sharing the
slides are
screen,
visible?
but yeah, now yes.
Okay. Hello, good evening, masters and my dear colleagues. Today my case is a tortuous RCA primary PCA complicated with detached intracoronary guide extension. So yes, there was a 66-year-old male who is smoker and presented in ER department with inferior MI, which was STEMI, and echo suggestive of inferoposteroval hypokinesia with moderate LV dysfunction. Heart rate was 90 beats per minute and blood pressure was 160 by 90. And patient was immediately shifted to the cath lab for the primary PCA. So here are the coronary angiograms. It's video playing.
No.
Wait a minute. I will share my whole screen.
You have not attached the link probably to the video.
No, sir. I'm just sharing my whole screen.
If you want to fix it up, then we can take the next person.
Yes.
Huh? Can
I
we
will fix it up.
can we ask the Maria Jyoti to present, and meanwhile he can fix it up his issues.
Sure, sir.
Sir.
Anushka, we can go to next person. Yeah.
Yes,
Thank
I
you.
think she's already started. Yeah.
Yes,
Let
yes,
her
thank
get
you.
started. Yes.
I'm just starting, sir. Is it visible?
Yeah, it's visible. Just go on a presentation mode.
Okay, sir. Yes, sir. 1 second. Yes, sir.
Yeah.
Hope my slides are moving. Yes, sir. I'll just start it. Good evening, sirs, and thank you for this opportunity for this presentation. I'm Dr. Maria, presenting on case study on low contrast PCI. As we know nowadays, many people would not go, especially the CKD patients and people who are, especially the nephrology part of it, elderly people would not go for the angiography, thinking that there may be an increase in the creatinine contrast-induced nephropathy and the risk of dialysis. Contrast associated acute kidney injury is increase in the serum creatinine of more than 0.5 milligram or 25% increase from the baseline 40 to 72 hours following the administration of the contrast. I present an 8-year-old gentleman who's been a known diabetic and hypertensive and ischemic heart disease for almost a year, managed elsewhere. And cardiac MRI was done elsewhere, which showed LAD was non-viable except the basal part, and all the territories of the L6 and RCA viable. Even we did the echo, which showed ECG sinus rhythm and moderate LV dysfunction with RWMA of the inferior and also the severe RWMA of the anterior apical part. And even I did visit, he did visited me like 2 to 3 times in the OPD. And after, because he continued to have chest pain past 10 days, and then he agreed to undergo an angiogram. Initially, when I saw it was 2.17, so I managed with the nephrology team and managed to reduce his creatinine to 1.57 because it was high initially, the creatinine clearance. And then we did the angiogram, which actually showed RCA ectatic vessel with proximally and then followed by a subtotal occlusion. We could also see the LAD distally filling retrogradely. At the same time, we also did an LAD shoot, the left side shoot where LCX was moderate and LAD proximal was around 70%. Diagonal also was tight, 90%, 99% almost, and mid LAD total occlusion with a blunt end there. So the approach here was a near total occlusion of a slow filling distal vessel, a tortuous vessel, elderly gentleman, LED being non-viable. So we had to do only precisely what is required. So we thought of doing IVIS guided PCI for him, a low contrast one. So we tried not to use much of contrast because already earlier it was already used. So 7 French, we took JR. Every time we could wire, it was buckling back. So I had to use an anchoring balloon with 6 atmosphere cyan blue wire. And then we were able to pass through with a microcatheter, drill the pilot, and then exchange with the BMW wire. Following this, after dilatation, pre-dilatation with 1.5 mm, we ran an IVIS to know that there is a calcium that has been present throughout with a fibrous plaque. Also, the area is being very low. We can see from 12 to 6 o'clock position, there is a fibrous plaque that has been there. As we go to the proximal part of it, in between the area is good, then falling. Again, when it is approaching the proximal part, the area is good, but again, the area has been coming down. This is the anchoring balloon, what we see here. And again, it is very less or narrowed. So what we could understand is there is a diffuse disease of the entire RCA, starting from the distal and till the proximal. So this is the fibrous plaque, what we see here. Then we continue to do the serial dilatations after 1.52 mm balloon. And there are some areas which I would highlight, especially this area where the calcium was so much. Even I had to go with the cutting balloon, then OPNC balloon 1.5 and 10, 2 into 10 mm OPNC because it was not yielding well. in this, we never used contrast with all these steps. Then subsequently, we used to do continuous IVIS. This is actually the IVIS run because it used a cutting balloon. Good amount of fibrous tissue was there, so it wouldn't yield if you don't cut precisely. So this is what we try to use. And this is after the cuts. We could see some cuts here. There are some discontinuation of the vessel. So the plaque area was modified a little better. This was a measurement which we were able to take, the pre-stenting measurement as well as the distal landing zone with a lesion area which was 180-degree calcium mark, which we tried to modify. So it came around 48 mm. Then we decided to keep that anchoring balloon where the wire was placed as a proximal part, and the distal area we measured. That's before the bifurcation. And then we deployed with 3 into 48 mm Zion's expedition. Then proximally we directed with 4 into 12 mm, and then post with 3 into 3.25 into 15 mm the rest of the vessel. Following this, again, we ran the IVIS to make sure how is the vessel expansion. We could see that it was not well opposed in the proximal part, as we see here when the wire is entering. That's the proximal part. So it was under expanded. So again, we went with the 4.5 into 6 mm vessel, and this is the end result what we got. So we were little bold enough that patient is tolerating well. We hardly used any contrast, so we went again with the left side. I tried opening with the left side diagonal because distal part was blunt. I didn't try again. So here we thought we would easily get over with only doing the with the Shion blue wire, but unfortunately I was stuck here because here it was very again difficult to pass through because somehow we used again a microcatheter again with a cutting balloon. We had to use OPNC balloon because when we across the diagonal, when we saw there was 360-degree calcium which was actually present, which was a surprise for us again. We knew it was there, but we got stuck there. We couldn't come back again. So we made sure that we used good amount of OPNC balloon of 2 into 10 mm, and then we dilated proximally with 3 into 10 mm cutting balloon. Following that, we directed the LED and we stented this is after doing all these things, how it has come. So we can see some cuts in that vessel, and this is to the LED part from the diagonal to the LED pullback. What we could see, it is opened up well. So even in the LED, there was lesion. So we realized that probably we have to stent even the LED. So after dilating very nicely, we made sure that 412 mm drug eluting stent in the proximal LMC to LED, then DB to the diagonal we did. And then we should do a pot because we did a pot of 4.5 to 6 mm vessel. Post stenting, again, we ran an IVIS to make sure how is the vessel, but again, here it was under expanded. So we made sure that again, we went with a higher atmosphere 5 to 6 mm balloon, and then it was the final result. I'll just show the final result. This was under expanded here, as we see here. So following this, after the 5M 5 into 6, this is the result what we have got. I've been following the patient, sir. It's been more than 6 months. He's doing good. And his EF also has improved to around 40-45%. And his creatinine, luckily, it is stable around 1.6 to 1.8. So we all know that IVIS guided PCI, any image guided PCI is always better than the angiography guided PCI because ultimate trial, there is a 3-year follow-up study also has come, the multiple trials where it reduces the target vessel revascularization with no, and it also helps us to understand the future rates. And whenever we place a stent, make sure that it is more than 90% expanded. We take the reference value and there is no edge dissection and very good overlap is there. And whenever it is lesser than 3 mm or 4 mm, we can actually use an undersized balloon and then try to dilate than putting another stent and make sure the plaque burden is also less. There are many stepwise approaches which is already available. This is actually what we see every day. What we understand by doing this low contrast PCAs, every patient, even a normal patient we do, should be considered to use a lesser contrast and try to use the various modalities what we have in the cath lab, like we have road mapping, we have stent boost, and we have even OCT with saline. So there are multiple ways where we can understand and specific angulation where we can see better two angulations and prevent the contrast load. So conclusion, PCA has been relied on contrast vessel opacification since its inception. Ultra low contrast PCI has improved both safety and quality of the complex intervention. Many complex PCI subgroups can benefit from ultra low contrast PCI in addition to patients with CKD. CKD patients have worse outcomes and increased risk of CVD, less likely to receive patient treatment, and these patients should not be denied the need of revascularization. Thank you.
A very nice case, Dr. Jyoti. Couple
Thank
of
you, sir.
things like ultra low contrast, there is a ultra low hemodynamic instability also, because this was clearly you might have done with the RCA and call the patient back again after a couple of weeks for either diagonal or LAD if you want to attempt. That is number one comment. Number two is that you have used a GR in RCA, while Shepherd Crook, one might think of getting AL to get a better support because you require an additional anchoring balloon. You
Yes.
have used a many OPN balloon. Have you considered any time going with the IVL after using at least a 2 mm balloon, and then you can go with the IVL anytime during this RCA angioplasty?
Yes, sir. But we thought of trying to mitigate the cost factor also was there because already
OPN is also like, 60,000
yes,
for the
yes, sir.
OPN, and
But
I think
yes,
I
sir.
could see 3 OPN has been
3
opened.
OPN. We have
And
only
yeah, so
charged one. Yes, sir. Yes, sir.
yeah, so that is, and diagonal was calcified according to the IVUS, and you have just done DCB. That was little surprise because diagonal is a large branch, and after opening with the OPN and cutting balloon, why only
Yes.
DCB to diagonal? You might
So
have
we did very
considered
good
for putting a
amount. Yes, sir. Stent also would have been there, but we thought we'll go with a hybrid approach. And the vessel opened up really well with the OPNC balloon. And when the vessel has opened up really well, we thought the drug, Dan putting too many stents for him, we'll try with the drug coated balloon. So it actually had a very good result. So we didn't upfrontly do it. We made sure the IVIS, it is opened really well. So with this, if the vessel has no major dissection, no flow limiting dissection, we can consider this one,
yeah.
DCB.
So it's a nice case, but just one last comment is like, people always present ultra low contrast and this thing, but I always tell my all the students that we should be also hemodynamics are also very important for the such a 80 years with anticipated calcified lesions in any of the artery. So I
Yes.
always say that stage them, so you can always bring them back and do the rest of the things. That's the only
Yes.
comment.
Yes, sir. But thank you, sir. And this patient was very reluctant, almost 3 visits in the OPD, 2 visits elsewhere. So we thought at least we'll try to do whatever best. And we've been following up.
Yeah, it's
Is
it's
doing
it's
good, sir.
nicely executed.
Yes, sir. Thank you so much,
Yeah,
sir. Thank you, sir.
nice case. And I think the drug-eluting balloon was a good choice there because it's a diagonal and it's a good choice and nicely done with ultra low contrast PCI.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.
Is the Krish is ready?
Dr. Krish, you're on mute.
Have you fixed the slide, Krish?
Yes, sir. I fixed it. Just wait a minute. I'm sharing my screen.
Yeah, go ahead.
Dr. Krish,
Dr.
you're
Krish,
on
your
mute.
mic.
Krish, what happened?
Dr. Krish, you are on mute.
You have to unmute yourself.
Am I audible?
Yes.
Okay. And are my slides are visible?
Yes. Now go on presentation mode. Yes.
Okay.
Perfect.
Sorry for interruption. Here the brief introduction of my case. He was a 66-year-old male who is smoker and presented in ER with inferior MI, ST elevation
अपने
MI.
जमाने के बेस्ट फास्ट बॉलर है, लेकिन फिर भी वो नहीं कर पाए जो आज जसप्रीत बुमराह कर पाए। बुमराह जो है अभी ऑल फॉर्मेट के बेस्ट बॉलर, पर स्पेशली
Am I
टी20
audible?
Yes.
Your
Somebody is.
Am I audible? Am I audible?
Yes.
Yes, please.
Am I audible, sir?
Yes, your
Yes.
slides
Dr.
are
Krish, you are
being placed
audible.
now.
Hello.
Go ahead, please.
We are
Am I
not able
audible?
to see your slide. You are audible. We are not able to see your slide.
Okay, sir. I could just now. Is it okay?
Yeah,
Yeah.
everything is fine. Now go ahead.
Yeah. The patient has inferior MI, ST MI with infrapostural hypokinesia, and he was hemodynamically stable initially at present and shifted to cath lab for primary PCI. So in coronary angiogram, we done by radial route with 5 French Tiger was used, and angio suggestive of LMC has diffuse 50% stenosis. LAD has non-significant lesion, and LCX was non-dominant vessel with 80 to 90% stenosis in OM branch. And the culprit was RCA, which was dominant vessel, anomalous in origin, and proximal RCA has 60 to 70% stenosis, followed by mid RCA has total occlusion. The video is running in the besides, and the recommendation was primary PTCA to RCA. So complexity of the case we faced during the procedure. So anatomical challenges was first anomalous origin of RCA. Second, according to the SCCHA classification, it was type C. Angiographic grading of tortuosity was severe in view of more than 2 bands and more than 90 degrees of the angles. Procedural challenges we faced during the procedure were first difficult RCA cannulation, second difficult lesion crossing with wire and poor guide support, third PTCA wire prolapse with loop formation in aorta, fourth event of Brady arrest during procedure, and last was post tenting detached guide extension shaft intracoronary. I saw the guide extension shaft, and after the in following slides I will show the whole procedure. So now we have started the coronary angioplasty. Primary PTCA procedural steps. Guide we took AL1 7 French by radial route, and the wire was taken was filter FC. XBRCA and AR2 was attempted but had a difficult cannulation with suboptimal and coaxial alignment. Difficulties here is PTCA wire prolapse into the aortic root while negotiating the distal occlusion. So we took the guide extension 5.5 French was used to prevent the wire prolapse in aorta and take extra support while negotiating the distal occlusion. So after that, we successfully crossed the total occlusion. We successfully crossed the lesion with the wire, and pre-dilatation was done with 2.5 into 12 NC balloon with support of guide extension. After the pre-dilatation, we faced the bradycardia arrest during the procedure. So we gave atropine and intracoronary vasodilators to prevent the slow flow, and after that immediately distal RCA stent was taken, which was 3.5 into 24 drug eluting stent, which was deployed at 16 atmosphere. After that, post tenting, the major complication was occurred. Post tenting, whole assembly patency was checked, and we found the guide extension was detached from the shaft and remained in the intracoronary. So the remaining broken part was gelled out with the support of stent balloon, and the whole assembly was taken out. Complete removal of the broken part was confirmed outside. So here is the broken shaft of the guide extension, and this was the balloon, stained balloon, which was extremely stretched during the removal of the guide extension. So finally, proximal RCA lesion was confirmed in a two orthogonal plane and stented with 4 into 20 mm drug-eluting stent at 16 atmosphere. And here is the final end result. So we achieved the very good flow in the RCA at the end, and patient was also hemodynamically stable. So take-home message is anomalous and extreme tortuous RCA requires proper guide selection, wire selection, guide extension, and other supportive delivery system. Stent with thin struts and good trackability. Post-stenting small check suit will always help to address most of the intracoronary complications. Before removing any hardware from the coronary, checking of whole system patency is always blissful. Thank you, sir.
Nice save, Krish. Two things. First of all, when there is such a tortuous RCA is there with acute inferior wall infarction, and you are dealing with 4.5 millimeter artery, PPM uh, temporary pacemaker is must. That is must. Number one.
Right, sir.
Number two is while crossing with the wire, rather than using a guideliner, I would have selected microcatheter where I can exchange to extra support wire, because such a tortuosity with the fielder FC, you will definitely find difficulty in tracking your stents with a lot of resistance and spasm in the proximal and concertina. So I would have taken microcatheter, cross the lesion, exchange into the extra support wire, and then probably life would have been easy. And I did not understand that your guideliner is broken inside the coronary, or it was broken inside the guiding catheter itself.
No, it was inside the coronary. After stenting, I want to remove the stent balloon, but the guide extension was very too much inside at the edge of the marginal branch, at the edge of the mid. So I have just pulled back some of the guide extension to avoid the LSD. So that when I started to remove the guide extension, and at the time I feel that there is a free movement of the guide extension shaft. At the time I noticed that something
So you have
something.
removed the whole assembly. You removed the whole assembly.
Yes. After that, there was a smooth movement of the guide extension shaft. I inflate the stent balloon at the 2 and 3 atmosphere and take the guide extension into the guide and remove the whole assembly from the radial route with the seat.
In toto.
And
Okay.
again rehook the RCA and take the another views and
Fine.
proximal stent.
Fine.
Krish, why did you use a 7 French guiding here?
For the very tortuous RCA, and I want to take the good support. And I initially I have taken 6 French XBRC and AR too, but every time the guide wire was prolapsing into the aorta, so I thought okay, I have to take an guide extension. So after that, I have choose 7 French AL1.
Was the guide extension a new arc or the used one, reused one?
Guide extension was old.
So you should also, you didn't tell it the take home point, don't reuse material, okay?
Yeah, right, sir, right. But we have
important.
cost cutting.
Even the balloon which got stretched was reused.
Yes, right, sir. All the system was reused except stent.
Yeah, so you have to be careful. So
Right,
next time
right,
you try to not use these things, okay?
right,
And
right.
I will not put a temporary lead. I will do exactly what you have done. I will never use a temporary lead unless the patient crashes with a complete heart block, because in acute MI, inferior MI, the RVMI is there and the chance of perforation is very high. So I will not use temporary.
The rate was 90 beats per minute. So
yeah, I will not use. That's what I told. I will not use.
Okay.
Okay. Thank you.
Thank you, sir. Thank you so much.
Thank you, doctors. So that brings us to the end of today's presentations for the India Coronary Conquest 2026. A heartfelt thank you to our course principals, Dr. Kamal Sharma, Dr. Dharmesh Solanki, and Dr. R.K. Jain. And thank you to all our presenters for those excellent and insightful case presentations.
Thank you. Bye.
Thank you.
Yeah.
Thank you. Good
So
night.
just a moment. I'll just give some details for the participants. So we'll be reserving the results for now, and the scores will be compiled from both the principals and will be shared over email with all the participants. And in case of any further updates, the AstraZeneca representatives will be in touch with the participants. So
So we will
thank you
update
again.
it by tonight on mail.
I'll send you by an email.
Yeah, we will
Yeah,
send
so
them by email.
the representatives will get in touch with all the doctors and you
Fine.
both as well.
Thank you. Bye. Good night.
Perfect. Thank you.
Thank
Good
you,
night.
sir.
everyone.
Thank you. Good night.